Good evening and welcome to NRAS Facebook Live. I'm joined here this evening by Dr. Lizzy MacPhie and Dr. Marwan Bukhari, and I've got Elsa Bosworth also standing by to ask a few questions a little later on. I'm Claire, I'm Chief Exec of the National Rheumatoid Arthritis Society, and you're all very welcome to this evening's broadcast. Tonight's going to be a discussion about how rheumatology has fared over this very trying time for everybody, and really how things are beginning. I hate that phrase of back to normal because I'm not that keen on normal, to be honest. I'd rather see, forward to better rather than back to normal. That's my hashtag, my mantra at the moment. So to kick us off, really, I'll come to you first, Lizzy. We've been told rheumatology is open and working for all, but evidence is showing us we're getting a lot of calls to our helpline of people that are really struggling and are finding it difficult to get seen. We had an example just this week of somebody who is in really urgent care but has been given an appointment for mid-October. So that's a hell of a long time to wait. So what can patients do, or what is, and I know you can't speak for all rheumatology units across the whole of the UK, but what is the general way of trying to get back up to normal service?
No, and I think probably the first point to make is that we've remained open, if you like, throughout the pandemic. It's just there have been pressures on services and things have had to be done differently. And I think it's really important to acknowledge that services have been hit in different ways because of where they sit. So, and also because of ongoing numbers. So Marwan and I both work up in the north, and we continue to see quite a steady stream of admissions to the acute trust, which is still impacting on the fact that for some departments, they are still having to support the rheumatology team in patients coming in with COVID. So there's still some redeployment out there for some units, which is putting additional stretch. And the other issue is that obviously because numbers are still high, we've still got quite large numbers of staff having to go off and self-isolate, having to move to working remotely. So, there's still those pressures on teams, and we continue to do the very best that we can to serve our patients. There is still a huge challenge for many units with reclaiming their outpatient departments, because most trusts, I think all trusts are still enforcing social distancing quite rightly. Though even though that's been relaxed sort of outside of healthcare settings, in healthcare settings. So we are still limited, because for many trusts that means you still can't bring up the volume of patients we're used to bringing up for face-to-face appointments. So still a lot of appointments are telephone. And that's a frustration, because patients, we know, we find it very difficult to escalate treatment. If we think someone's active over the phone, we will do it if it's really needed, and if we feel it's safe to do. But for many patients, you want to examine the patient and check their joints. So that continues to be a struggle for us as clinicians to work safely, and also for our patients, because many want to see us. So to how to sort of advise that patient who you gave the example of, who's not got an appointment till October. The vast majority of units have advice lines, and even though they were very stretched at the start of the pandemic, I think that's one of the things that we are all heavily investing in, making sure that those remain are open for patients. It may be taking a little bit longer because of pressures on the team to get back to people, still, just because of staff self-isolating and such, and people being off. And we're coming up to summer holidays now as well, which puts additional stresses. But ring the advice line, and make some notes of how your arthritis is faring. Describe to us, if your joints are swollen, how long you've been struggling for. That information, make some notes, so that when you get faced with those questions, tell us what you've tried, what's been done. I know that a lot of patients are then contacting GPs, and then we'll get letters or requests from the GPs to see patients, but GPs are equally frustrated that they're having similar challenges. And I think rather than, burden the system on two ways and go and see to your GP, I would encourage you to probably, try and, keep contacting the team, and through the advice line is probably the best way for most units, and have that information to hand. And if you're offered an appointment and your disease is active and you've got a choice of being telephone or face to face, if you're struggling, it's so much better for us if we can see you face to face, because then that means we don't have to bring additional patients back to then assess them, to then escalate treatment. So if you have the offer, then please consider that, because it does mean we can get your treatment escalated more safely, and for a lot of units.
And you touched on remote working, and coming to you, Marwan, how are the remote consultations working? You said, Lizzy just said that sometimes you have to see the patients, but it's getting that balance. Are people being, perhaps a little reluctant now to come back into the face-to-face, do you find?
Oh yes, we've got two sorts of patients that you've got. You've got the very busy patients who don't necessarily want to have their disease controlled as well, who basically will be quite happy to be phoned. And I have been known to do phone consultations with patients, in cars, in supermarkets, and in other places when they actually knew we were going to phone them. And so you can tell that very frequently that's not the biggest thing on their mind, which means that they're distracted by what's around them. And we're distracted slightly by going, hang on, I'm talking to a patient who's, somewhere outdoors doing a different activity. And so you can't really assess the patient very well. And then very infrequently, you've got the patient who's really not wanting to escalate the treatment as much as we would like them to. We would like to get the control of disease better, who will always say, you can only see the patient from a certain angle. And if usually you can't tell from the body language whether they're stiff, whether they've been limping in to see you in the clinic. And so usually you can spot a big swollen knee or somebody who's having a problem with their shoulders just by the way they walk into your room. And that's part of the consultation we don't get. What we're trying to do, some units are trying to actually get questionnaires that correlate with disease activity. If you've heard of the AIMS-2 questionnaire, which the Americans use a lot, and they correlate with disease activity. So if you get some questionnaires coming your way, they can sometimes be very good indicators for us to be able to assess how active your disease is. And maybe that's one of the ways that you can do it remotely. And importantly, if we're seeing a patient face to face, we can then usually organize blood tests looking for active inflammation in the blood very, very easily. While you're out there in a remote consultation, even if you ask for it, the patient will then have to phone up, make an appointment, be in a queue to be able to actually just get a blood test. So that amount of time isn't satisfactory at all from our point of view, because it delays the time from us making a decision. So one of the pleas I was just going to make to the last question, that if you're struggling at home, one of the things you might want to do to shorten the time to a decision to be made between yourself and your clinician is to actually go and have some blood tests done and look for inflammation. Inflammatory markers are quite important here, because they will make that shared decision that you make with your clinician, but be it your nurse, your physio, or your doctors, much easier to do.
And would you recommend that when people go for those blood tests, that they're being specific as to which blood tests they're asking for? Would it be an ESR as anti-CCP, or what is it? That again, more informed patients asking for the right sort of blood test, I think.
Yeah, well, ESR it depends where you are, but ESR is a good test to have. A CRP is probably the one that is probably obtainable in every single unit around. Some units don't have ESR; they do they do other tests to look for inflammation. But as long as they mention inflammation blood tests to whoever's doing them, usually they'll understand what they mean. Because I'm forever getting people who say, "Oh, I've had my bloods done yesterday," and you look and you've like, there's a full blood count and a liver function test. That doesn't necessarily help me get the patient sort of like onto the treatment you'd like them to be on.
So that's a really useful tip for everybody that's listening. And just to let you know, we've got 83 people watching us at the moment, so you're all very welcome, and I hope you find this interesting. If you've got any questions, please keep them general, but you can put them into the Facebook chat, and you know, we'll do our best to get to as many as possible. We do have some that have already been submitted. So yes,
sorry, can I just mention something, because Marwan mentioned about the aims. Another way is that we've now got our video showing patients how to do a DAS 28.
Yes,
and how to examine their joints. So I know that you guys at NRAS have done quite a bit of work promoting that, but it's basically a video that's available on YouTube to help patients understand how to examine, and you've got your DAS app and everything. So it's again, it's another means by which patients can give us the information about how their disease is. You know, and if patients have gone to that sort of trouble and can tell us, well, this is how many swollen joints I've got, I've watched this video, I know how to examine my joints. It's just more information, you know, that we can pull together. And certainly as a department, we're starting to now use that particular tool through the BSR platform. They've built a platform so that we can push questionnaires to patients to fill in, and that really helps us in between appointments for patients to be able to tell us how they're doing and when they're struggling. And I know not every department uses that, so I don't want to sort of focus too much, but anybody can access that video. It's from the Remora study, and I'm sure you guys can probably post a link somewhere on.
Yes, we'll be able to pop a link in to that, and also to our Know Your Disease activity, because it's still surprising how many people that we speak to on a regular basis who don't know the disease activity score, or haven't even heard the term. And for anybody with rheumatoid arthritis, I'm always saying that you know, if you had high blood pressure, you'd know what your blood pressure was. If you had high cholesterol, you'd keep an eye on your cholesterol level. If you've got rheumatoid arthritis, know what your disease activity score is, because it really does help you as an individual to see how well or not your treatment is doing, and it really helps to keep that dialogue going. So hopefully my colleague will be able to put a link to the Know Your Disease activity score, and there is a link there as well to the Remora clip on YouTube as to how to examine your own tender and swollen joints. So another question here. Are you, you know, with newly diagnosed patients that you might be seeing now, somebody has asked, are you seeing any correlation between somebody being diagnosed that has recovered from COVID? Is there any links there, or, you know, is it too early to say, really?
The studies so far have been trying to say there's links between, you know, either COVID igniting rheumatoid or the vaccine starting rheumatoid for those who started their disease. The problem is that you can't really prove what we call causality. In other words, there's a high amount of people who've had COVID, and almost everybody's had the vaccine. So the fact that you've developed a disease after the vaccine doesn't necessarily mean the vaccine gave you the disease. So it's like blaming your accident on your bike on the vaccine if it happened, you know, half an hour after you had your vaccination. Yes. And, you know, you had the accident. It doesn't happen. People get the disease, people have the vaccine. Linking the two is going to be interesting. But we haven't seen an uptake of new rheumatoid arthritis as yet, even globally. So I work for a journal, and I see quite a lot of the papers on COVID come my way. And even globally, we haven't seen an upsurge in the number of people with new onset rheumatoid arthritis. We have seen new onset of people who have been post-COVID having joint pains and muscle pains and not feeling well in themselves. That's something slightly different. That links in with with long COVID, with fatigue, etc. So it's slightly different from what people are saying. So no, the answer. There's always a corollary question to that one. Does the vaccine cause your disease to flare? Again, we've not had any evidence for that, but almost everybody will say, I had the vaccine and then 6 weeks later I flared. I was like, well, actually that doesn't necessarily fit with how the vaccine works. So flares will happen, vaccines will happen. You can't really link the two.
Exactly, that's very clear. Thank you very much, Marwan. So both of you at your units have been dealing with backlogs, no doubt, and you talked about the measures that you've been putting into place, and of course it's quite different. Both of your units are quite different because you've got a rheumatology service in the community, Lizzie, whereas Marwan, you're at a hospital. So what you were saying about the shared outpatients area, is that causing issues in your hospital, Marwan?
Yeah, so in our hospital, we've had several problems. The first is that because the hospitals have had to be zoned, some of the what we would call the old outpatient areas have been taken away so that they can put the patients who are what we call super green, who have been isolating for 2 weeks and are coming in for elective surgery, who have to be kept away from the rest of the hospital. And so a lot of the outpatient facilities have been taken towards helping with that. And the rest of the outpatient facilities have been spaced out, so you're not allowed to have any more than N number of patients waiting at any one time. And that reduces the numbers of patients that you need to have. You've also got to clean and you've got to clean the room in between patients. So there needs to be a wash down of each room. So it significantly impacts things, not just with space, with the number of people you can see and with everything else. And the fact is, we can't examine a patient. Our local hospital means that you have to be wearing rubber gloves and a pinny and a face mask before you touch your patient. That also increases the amount of time you need to do it. You can imagine just how warm it's been over the last couple of weeks.
Yeah.
And you can see how shiny my forehead is. I just finished an afternoon clinic. So,
and following on from that, I mean, what has been the impact on morale? For you and your colleagues, you've been working flat out pretty much without much downtime or break or lull for the past sort of 20 months or so. What is the impact on your colleagues, on yourself, on your the rest of the multidisciplinary team?
Yeah, I have to say the team got disintegrated at the very beginning of it. So in the hospitals, most teams will have been disintegrated. We lost our specialist nurses to intensive care on the wards. The rheumatologists were given a COVID ward and said, there you go, get on with it. And we had to work 5 days on, 2 days off for quite a period of time, and neglecting a lot of our patients while we're doing that. We managed to when we got back to our departments, we were told there's very little you can do. You have to do things on the phone. We had to understand how to assess our patients on the phone, try and get the team back together. And it's been difficult because you can't get the team physically into the same room. We're having to use this sort of medium. So we're going into Teams and doing a lot more of things that are slightly more challenging to actually get for team building. And I think everybody agrees that we're now, I don't know how many months down the line, and everybody is possibly sick and tired of Teams and Zoom and doing things like that. And we really want to have that interaction, both with our patients and within our teams.
And within colleagues, yes, definitely. I mean, we could certainly probably all relate to that. I'm convinced there'll be a new disease called Zoomitis that we'll all suffer from. Lizzie, coming on to that and talking about workforce, the British Society for Rheumatology recently published an incredibly worthwhile report on rheumatology in crisis. And, some of the stats out of that are quite alarming, to say the least. The variance across the UK. But some of the recommendations, are very clear. And what can we as a patient organisation, what can our patient population do to help bolster some of these recommendations? Or what comments have you got on that report?
I think that the biggest sort of messages coming out of the workforce report is we are very understaffed. And we need more consultants, we need more nurses, we need more physios. We have a handful of psychologists working within rheumatology up and down the country, but like you say, that geographical variation is incredible. And so, there's some very sort of top line things about how we need more people to be recruited into rheumatology across all of the, the doctors, the nurses, the physios, OTs, etc. We need more, medical students coming through, opportunities for them to be exposed to rheumatology, and more opportunities then for people in their training as junior doctors and nurses to have exposure to rheumatology. And one of the challenges for us in rheumatology is that we've moved from being in hospital and having wards of patients because of the advances in the treatments and how we manage the disease, that we don't have wards of patients now, so we don't get the same exposure with junior doctors doing a rotation on a medical ward or such. As far as patients, raising awareness. So if you have the opportunity to be asked by your rheumatology team to get involved with doing medical student teaching, please take it up, come and tell us about your disease, because the more exposure that medical students have, the more it thinks, what, I quite like that specialty. They can also, when you come and do expert patient teaching, they see that relationship between your doctor and your nurse, and they're like, oh, these guys really get to know their patients. I often explain to medical students, I grow old with my patients. I see them go through so many life events. And it is a wonderful specialty from that perspective. It's not everyone's cup of tea, and I acknowledge that, but having those opportunities, if you have the opportunity to be sat in clinic and you're invited that a medical student or a trainee is sat in, or would you speak to the medical student, please do your bit, because those interactions sometimes sow the seed for someone to think about rheumatology in the future. And I can't tell you how many times I've had medical students come back and say how valued those interactions with patients have been. So we struggle because we don't have much opportunity, but if we can make absolutely every little interaction they have in a rheumatology setting worthwhile, and get them to see those relationships between the team, get involved with teaching, they're invaluable. You probably don't realize the impact you have. So that for me is sort of a plea as to what you can do as patients, and bang the drum for us working differently. Our specialist nurses, we have skilled up our specialist nurses so that they're doing a lot of the work that they can do. I don't have to see all my follow-up patients because we've skilled up a team. We've got our physiotherapists assessing patients and escalating treatment where appropriate, doing joint injections. So be kind to the team, because we work as a multidisciplinary team, and there's a little bit of an expectation from some patients to see the consultant every time. We're a consultant-led service, and if we take that approach with everybody, then we won't be able to function, and we won't be able to see the people who most need that really specialist and the challenging care. And the key message for me to every patient is, when I've got a patient who's a bit reluctant to see a specialist nurse, or they've maybe had a challenging consultation, and they said, well, I'd like to see you next time. I say to them, but if this happens every time, it means that when I really need to see you, you might not be able to get us in easily to see me. So that might be just another thing just to think about, is that when you're, it's lovely to see your consultant every time, or a trainee, but
it's not always
necessary.
I think it's about utilising the service in a different way. And as you said, the really skilling up, not just specialist nurses, but physios with an extended scope practitioner, pharmacists now with a special interest in, say, biologics, etc. There's a whole team of people that have expertise. And I think that there is a bit of a mind change switch that we need to accomplish. And I was just, in the BSR report, it's recommending, one consultant, one specialist nurse would, and I thought, we were just talking before we went live, that was quite a huge aspiration, whether that would ever be possible. But actually, both of you have said that that is possible and you've got it, but it isn't across all units. And sometimes it is that not valuing the rest of the multidisciplinary team as much as they should, and especially the specialist nurses. So
I think units which don't have enough nurses probably won't have enough consultants either. So probably most go hand in hand, that if you've got a critically understaffed unit. So you quite often see that pattern. And some units just struggle to recruit geographically. They're not attractive. I know that sounds terrible. We really struggle in Preston because we are so close to Manchester that all our trainees want to stay in Manchester. That's where they all live. So the idea of commuting up to Preston, they're like, oh, I'm not that's too far. I can get a job down the road. So, you know, and Marwan has similar sort of challenges up in Lancaster, don't you, Marwan, with recruitment, because most of our trainees want to stay within Manchester. So the more attractive we can make, and the more we can think outside the box with how our models work and such, I think is really, really important. And I think patients can play a really important part with that. And with getting involved, you know, if you're asked to, we need your views on, you know, what you get out of the department, feedback, you know, just, you know, get involved with those discussions, because that's how we change departments, and how they, if you're asked to come and get involved with a discussion, or people are looking for for patients to get involved, then
absolutely, yeah.
Can I make another point that what patients can actually do? Two other little things. One is to actually increase awareness amongst the lay public about the disease. So when you're seeing people around, you know, the misconceptions that, you know, arthritis is something that only happens to old people, etc., is still alive and kicking. And you still have to be able to sort of like say, no, actually, rheumatoid can affect people, you know, from all sorts of ages, and that does happen. And the last one is, if you're involved in any way in local politics, you can actually try and influence your local councillors and your local MPs to say, you know, my rheumatology department isn't up to scratch. Can you get that? You have the ability to get parliamentary questions happening. If you know that you've got a department that's struggling, and there's a department just north of me that can't really recruit very well. So I'm seeing lots of patients from the north end of the Lake District. You know, if anybody knows it, they can lobby the MP, ask a parliamentary question. What is the trust doing to bolster the care of rheumatology patients in that part of the world? It's something the patients can do, we can't.
And exactly. And I think sometimes perhaps individuals are reluctant, thinking they're going to get their hospital into trouble by saying they're not, you know, fully staffed or whatever. But actually, you're bolstering their plea for more support and more colleagues. So, and that's a great way of getting involved in NRAS. If you want to, if that's the sort of work that you would like to, we're very keen to speak to you, because we can give you all the right sort of resources to speak to your MP, or to speak to your local CCG, or what's it now, the ICSs. There's so many new acronyms to get your heads around. And so but do speak up. It's not you being an awkward patient, it's not you being, you know, a troublesome one. You're actually helping your rheumatology team to build back better, which is what we really want to see. Now, there's a lot of questions coming in. Of course, they're all over on various different topics, and I'm going to try and capture some of them. But I wanted to say, some people are, of course, now coming out of, you know, restrictions have been lifted here in England. I know it's slightly different in Wales and Scotland and Northern Ireland, and there will be people from all four nations. And actually, we have somebody watching from India, so I don't know what the circumstances are in India for you, but being encouraged to go back into the workplace. And the government guidance is that it should be, you know, if people are concerned about whether they're still at quite high risk, or you know, they are immunocompromised and don't feel that the workplace is a safe place for them, that they're instructed to get support from their clinicians. Now, from what you've said, you don't have time to be writing all these letters on individual cases about their RA. So what would you recommend patients do when they're sort of caught between a hard place, you know, a rock and a hard place? Their boss is saying, I need to see a letter from your doctor. And we have the information on the websites and everything about what should be acceptable in the workplace. But, you know, are you finding that you're getting more and more of these sorts of requests?
We've had
not
some.
Really, but we do get occasional ones, and we do support them when somebody feels that there is a problem. So I had a patient who was a teacher and was looking after a lot of unvaccinated school children who didn't necessarily have the ability, who had learning needs, and therefore didn't understand social distancing and all of the different nuances. And that was a special case, and therefore I supported him to say, I think, really until we have all of the vaccination, the boosting happening in the kids as well as the teacher, then that's a special case. But you have to just take each case differently. I mean, I had another patient who was, a forklift driver who works on his own in a cockpit and was thinking, should they be shielding? And I'm going, oh, hang on, no, you work on your own. There's very little risk here. So that comes
his own bubble. It's literally his own bubble.
Yeah. So they're different. Different models exist for different people, and different people have different not expectations, but they think that because they're on a biologic, for example, or they're on methotrexate or they're immune suppressants, that they'll get the disease easier, possibly not. And if they get the disease easier, they'll actually be worse off with it. That's almost certainly not. And that the drugs that they're on are bad for the disease, that's definitely not. So we've got several bits of misconception about the disease and the drugs that you've all got on the website. So go onto the NRAS website. There's a Versatile Authorities website. There's lots of places to get information.
And it's probably something to add, the clinically extremely vulnerable group, there's still different advice out there for them. So if you have been identified as in that group, then there is specific guidance for you that is still about if you can work from home. So that particular group still has some protection there, but that will in due course also be relaxed, should we say, that guidance. But I think Marwan makes a really good point. I can't tell you how many discussions I've had with people where they don't realise that our knowledge now is very different to how it was back in March 2020. We know from really, really good studies, from registers, that patients haven't done as badly as we thought they might do if they got COVID, and the drugs aren't as risky as we thought they were, and actually having active disease is much more worrying. So some of it is about actually helping people to understand their risk and also helping them to understand what they can do when at work. Even though people don't have to wear masks, you can still, wear a mask, and you can still make sure that, well, actually the office I work in is socially distanced. People can still have those conversations. I know it's not possible for every single job, but I think it's fair to say we would always try and support those cases where there is a really strong case. I've recently done a letter for a young girl who's terrified of going back into college, who's on very, very significant medication, high dose steroids, and her sadly a family member died of COVID, a very close family member, and she's terrified. And she cannot go into lessons where she can socially distance and such. So we've made a special case, and school have been very understanding. So I think, like Marwan says, but we can't write letters for every single patient. We will get swamped.
No, exactly.
But understand, empower yourself with the information about where we're up to, because it isn't as scary, and a lot of patients haven't realised, and your website is brilliant with all of that information. So.
And I think there is, it's such a catch-all terminology, immunocompromised, immunosuppressant. And that goes right from the people with blood cancers and kidney transplants who are, are very, very immunosuppressed compared to the other end of the spectrum as well. And so it's difficult when the JCVI talk about immunosuppressed medications. So generally when it's very different for people with RA compared to somebody with leukemia. And that's where I think a lot of the fear is coming from. We are still waiting for the Octave final results to come out. I know we talked about this on a earlier Facebook Live last month with Professor Ian McInnes, and people have been asking for it. We haven't got them yet. As soon as we have those results and we have the lay summaries, we will be sharing that, of course, with you. But so far, all the indications are that the vaccines are certainly giving some, protection, maybe not as much as somebody that is not on a immunosuppressant, but they are giving you protection. And we would strongly recommend, if there's anybody out there who has not had their vaccine, to please, please, please do so for yourself, for your families, and for your neighbours, of course. Changing tack a little bit from the vaccines and COVID, there is some people talking, quite a few people talking about still very much struggling with fatigue. And there's so little we can do about fatigue. We do have a resource, of course, that we about what you can do to pace yourself on fatigue. But what are your tips or suggestions to patients who find that the RA seems to be controlled, but it's still the fatigue that is causing them the most problems? Which one of you wants to answer that one?
I'll quite happily start with, there's several things where if the disease is very well controlled and the patient has still got fatigue, there's several reasons for it. You've got people who've been indoors and have not really exposed themselves to enough vitamin D, and they could be a bit low in their vitamin D levels, and that could be one of the reasons that patients have got fatigue. The other is as a very big bugbear of mine, which is sleep. Now, if people are not really having a good sleep hygiene and good adequate sleep where they rest all of their muscles overnight and wake up feeling slightly refreshed, then they might want to be looking at their sleep hygiene. And there's a lot of work being done about sleep disturbances in some of these patients. And sometimes you can pick up that there could be, it could be simply things like, is there a bit of an anemia there? Has there been a bit of low, is the hemoglobin slightly low that is causing the fatigue? But if the rheumatoid arthritis is fairly well controlled and there still is fatigue, there could be a correlation with a relatively not far away disease called Sjogren's syndrome, where you have dry eyes and a dry mouth. And one of the cardinal bits of that disease is fatigue. But I don't find that very often. Most of the time I find patients are really either not sleeping very well or have, there are sort of deficiencies within diets, etc., and they're vitamin deficient. Those are the two big ones in my head. But Lizzy, you can probably elaborate more.
Yeah, I think for me as a health professional, one of the big things for my patients is acknowledging it. And, when I give talks to sort of trainees and, to the team, I think actually just acknowledging that people, we might be saying, oh, your disease is really well controlled, but they're still feeling shattered. Yeah. And, we know that even patients with well-controlled disease. So yes, there can be, as Marwan's described, some very good reasons that people might be struggling. But I think at the moment, I think I'm spending a lot of time giving people permission that it's been a really tough 18 months. And a lot of our patients are very worried about return to the new normal, however you want to put it. And they're very anxious. And I think there's a lot of anxiety wrapped up in. And when you're anxious, that takes an amount of energy off you. Homeschooling, now it's school holidays. And then we've had all these stresses of self-isolations for people with, kids on off school, trying to hold down jobs, work from home, new puppies. There's just been so much going on this last 18 months for patients. I think we all need to give ourselves a bit of permission that actually, I think there's a lot of fatigue out there, not just for our patients, just generally, and the frustrations of the system of having to learn new ways of doing things. I mean, I said to a patient the other day, she says, I just feel exhausted at the moment because I'm starting to go and back into, but it's the stress for me. And I said, well, it will be, if you're starting to go back to, she just started back up again at a very, very well-spaced exercise group for older ladies at her church hall. But she said, I was 3 times as exhausted. I said, well, you haven't done it in 18 months. And the other thing is, it will be extremely stressful just going there. And that in itself is tiring. So I think be kind to yourself about.
Absolutely. And I think that's 2 things to just comment on there that somebody mentioned about how stress can trigger or exacerbate rheumatoid arthritis. And it is a piece of work that we're going to start looking at later on in the year, just doing some survey work, but also developing a resource about how stress matters and how we manage stress. And on that point as well, last RA Awareness Week, last September, we responded because of the impact of COVID on mental health and emotional health. We did well-being sessions during RA Awareness Week. They were so successful. We've now launched, I think we've got 14 sessions going on throughout RA Awareness Week, which is in September. And hopefully one of my colleagues will post in the Facebook Live the link to where you can find information on that. But it's in the event section of NRAS, the website, in the event section. And you can sign up for any of these taster well-being sessions on mindfulness, on Tai Chi, on chair yoga, on nutrition, all those sorts of things. And already we've had something like 700 people register for various different ones. So there's support out there to deal with these things. And again, regarding sleep and managing your sleep, we have an excellent article on the website by Sue Peacock around sleep management. And we've all got out of the habit, I think, of valuing sleep and being in such a sort of busy environment and a rat race that you feel that, by sleep, it's almost like, sleep is for wimps. It most certainly isn't. You cannot function if you don't get decent, good sleep, and prepare for sleep. We're all, as you were saying earlier, Marwan, we've all been zooming, screen time. Our screen time must be through the, because we're not having those face-to-face meetings around a table. It's all being done on screen. And I think that does have an impact on your sleep patterns, because you've been just constantly looking at screens on mobile phones, on devices, etc. So it's we need to kind of switch off, and that's not just switching off our heads, but also switching off devices as well. So there's a lot about sleep on that thing. Elsa, you've just said you've got a question on sleep. Would you like to come on down?
Hello. Yes, I wonder if either of you can comment on something I was told recently, because I have major sleep problems and have had for a very long time. And somebody told me recently that magnesium can help with less restless leg syndrome, which is something I get periodically, where I cannot lie still. And if you can't lie still and you're thrashing about all night, you end up not sleeping. So should I be going out and getting some magnesium?
I'll let Marwan knows the evidence.
Yeah, the evidence base for it isn't that big, but from what has what's happened out there, rather than in just rheumatology populations, there has been some evidence that around 30 to 35% of people will respond to things like magnesium, gabapentinoids like gabapentin and pregabalin. Again, they're not necessarily the best. Amitriptyline, there's some evidence for with restless legs. And there's even some evidence to just normal thiamine that does seem to work with restless legs. So there's no one medication fits all, but people will have to just explore what works for them.
Well, the other thing is there was some good studies a few years ago about low ferritin. So if I have a patient with classical restless legs, I check their ferritin, because sometimes if people are iron deficient, that can cause restless legs. And there is an actual diagnosis called restless leg syndrome, where you have criteria to meet, and there is a specific medication. Is it Ropinirole, Marwan? Yeah, which is a specific treatment. Now, that's not directly associated with rheumatoid arthritis. I think what we've got to be careful about here is, whether there may be a separate issue going on that needs specific management. I think it's so difficult with so many of the complementary medicines. And I often say to patients, look, we don't know the answers to everything, because not all the studies have been done, especially on the complementary medicine side. And I do spend quite a lot of time saying to patients, look, if you want to try something, just make sure about interactions, and we can usually give them a bit of guidance about that. And I say to people, if you want to try something for a couple of months, then by all means, I have no objections, but just give yourself a time scale as to when you're going to reassess if it's making any difference, because you can end up spending an awful lot of money on supplements.
Sure.
But you need to make sure about drug interactions. Magnesium is one of these things that is you're probably not going to get into any major issues.
And before you ask, cannabis oil is another one. Somebody will always ask about cannabis oil.
I haven't gone down that route yet, but yes, so thank you. That's interesting.
But just you mentioned CBD oil, and there is we often see that sort of conversations on our online community on Facebook, etc. And I think that the concern is there is an awful lot of products out there that are not regulated in an appropriate way, so you never know quite what you're getting. And that's the concern. Again, there's an article on our website just to give some guidance on that, and we're constantly keeping an eye on that until we have the evidence either way, and on how to keep people safe as well on that. We do have a question about it seems like we've had quite a bit of contact from people on rituximab who appear to effectively have to start requalifying for their next infusion. Is that something that you've come across, and it's causing longer delays? It's because they've if they're due to have their rituximab now after 8 months, 10 months, 12 months, so they're having to go in and get reassessed. But that's happened in a few different occasions. So we're not sure
what do you mean by requalify? They have to.
So they're not just being called in for their next rituximab infusion, that they're having to go and have their DAS score done and everything.
Okay.
So
this is difficult because for a lot of our patients, on rituximab, it can be very variable when people need it. And for many patients on rituximab, we can find that they can go longer in between each infusion. So not every patient needs it every 6 months or every 9 months or every 12 months. Some people will follow a pattern like that. But we found over the years that quite a lot of our patients do vary just because of other things going on in their lives. But we do see a definite pattern in some patients where they can last longer in between each infusion. The other thing about rituximab to realize, it has been a worry drug for us because of how it works, and it knocks out your B cells, which are your antibody producing cells. So if there's one drug that we've been worried about, and this has come out in the studies that have been published, rituximab is a wobble drug for us, for want of a better way of putting it. So I think a lot of departments will be making sure that it's definitely justified to give another infusion at this time, and making sure that the patients understand the implications of that. Timings of vaccines and such is really important, and now the boosters as they start to happen going into September. So it might be that it's your teams making sure you definitely need it. And as I was saying, we don't have any rheumatoid arthritis patients who are on fixed regimes. We would always, as a department, assess, make sure it's definitely needed, and then list. Marwan might, I don't know.
No, we do exactly the same thing. We don't have a every 6 or every 9 or every X number of months. We just reassess patients. And maybe sometimes the reason for reassessment might be because we want to see if we can give the patients the rapid infusion. And because there's the longer infusion time for rituximab takes a lot of time, takes up a lot of space. And a lot of people now, because the infusion facilities have less capacity, you're trying to make sure that the people who go into the infusion facility actually do need it and could have the rapid infusion, especially if you're on one of the newer biosimilars. We need to be absolutely sure that that's the case. It needs to happen. So if you're on Truxima or Rixathon, that's where you'll be looking at that. That's what possibly people will be looking at to say, okay, we can't really give all the people we used to give rituximab. There's no space. So we've got 3 infusion facilities. Back in the day, it was 10, 6, and 10. It's now down to 6, 3, and 6. So you can imagine just how much, and that includes people needing blood transfusions, people needing iron, people needing zoledronic acid for osteoporosis, people needing infliximab for other reasons, for gastro reasons, etc. And we share those facilities with them. And most hospitals will have the same issue, in that their infusion facilities are shared and they have to be rationed.
Can I just clarify a little bit further on this, because I'm speaking to somebody on Friday who's had this very problem, and to the extent that the delays have got longer each time because of this having to requalify. The impression that we've got is it's the CCG that are asking for the requalification, and to the extent that on this occasion the flare got so bad that he's actually lost his job, and that doesn't seem.
Yeah, so we have a responsibility to confirm to the CCG that a patient continues to respond to treatment, but that isn't about requalifying. That's us providing, and there are now forms in place for most units, that's called blue tech forms,
Right.
Where we have to provide those assurances to the CCG that the patient continues to mount an adequate response. But that doesn't, you know, that shouldn't prevent, as I said, this business of requalifying. My slight concern is that this individual might not be having as good a response as they have previously. So maybe the team are maybe nervous about giving them more and need to have that discussion with. I don't know. But I think there probably needs to be a bit more unpicking of that particular individual, because the evidence that we provide to the CCG for most intentions, the form we fill in is just literally a tick box. Please, can you confirm patient continues to respond? Okay. We don't have to provide anything more than that. And a lot of the CCGs have relaxed quite a lot of how often we've had to send in follow-up forms at this time. So they have realised that it was an extra administrative burden. And also we just couldn't provide the forms on the 6 monthly basis like they were previously asking for, because we weren't able to get people in to see them to do. Yeah. So we have had a bit of relaxation locally with respect to the completion of those forms. So you probably need a little bit more info. Yeah. And
I think what your colleague or your patient that you're talking to means by requalifying might need to be just explored a bit more. Does a requalifying mean that they've got active disease of more than 5, the DAS score of more than 5.1, or is the requalifying have they failed 2 other disease modifying drugs and are going to go there? Or is it that their locality is slightly restricted with the number of drugs that they can give? Now, Lizzy and I are in a very happy place in that we have, we've got some leeway with what we can do. But I can understand that some geographical areas might not have the leeway to give people more than 3 advanced drugs. So, just understanding where that person is in the pathway, and whether that's their last drug of, they've had a TNF drug and something else, and rituximab is their last, and they can't go anywhere else from there. It would be a good thing to understand.
And just talking about, advanced therapies, it leads on nicely to, of course, we had the fantastic decision come out from NICE there recently that we can, that people of classified as moderate disease have now the option for some of the advanced therapies, not all, but some of them. And one of the things I really wanted to get across tonight is just managing people's expectations, that you may be in that moderate category, but it won't mean necessarily like your very next appointment you're going to start an advanced therapy, because it's going to take some time, as you said, to assess. It won't be for everybody who's in that moderate category, it will be for some. And of course, that's adding probably more workload to you already. How are your units planning to do this and phase this in over the next, I would think, the next 18 to 24 months before, we're able to really get through everybody? What's your opinion on that? I'll come to Marwan first.
So the wording that we're hoping to have in the shared guidelines, actually, Lizzy and I share we're an accountable care system now, I think, are we? So we're about to all merge into one big happy family four big trusts in the north of Lancashire, South Cumbria. And what we have done is that we're trying to word it very nicely, that the NICE guidance is very clear that you have to have tried 2 other disease modifying drugs before you go on if you have moderate disease. And to an extent, the ones that work best on need to have also evidence of active inflammation. And so very frequently, if you've got somebody with a lot of tender joints and who is to an extent attributing the disease activity to the fact that they're actually having problems with sleeping, with stress and everything else, but don't necessarily have the disease activity that makes everybody go, that the drug will work for you. Mm-hmm. That doesn't necessarily happen. And we've seen this from the data we've seen from the registries around the world, that with patients with moderate disease, the more amount of swelling of your joints, the more amount of inflammation in the blood, the better the response is fairly clear. And so you do, and these drugs do have their own bevy of things that we worry about, and we have to monitor them, and there's a lot of caveats that go with the drug. And we always have to balance in our head, are we doing the patient more good than harm by exposing them to these advanced treatments? And that's a conversation every clinician should be able to have with the patient, to say, am I doing you any good by exposing you to these drugs? Because every practitioner will tell you, we love and hate certain newspapers. I'm not saying anything, but they end in mail, and they come through. The patient will come through with an article saying, "I want this," and you're going, actually, your disease doesn't fit the category of what is happening here, and the criteria don't allow you to go on to this. And if I give it to you, it's probably going to do you more harm than good. And that is, I spend a significant amount of my time doing that occasionally, especially when I'm working somewhere, like Kendal, in which case the newspaper ends in graph.
And I think it is that rheumatoid arthritis is such a complex, it isn't a disease, it's a syndrome almost. It's very variable from one person to another. And I think that's where people, when they see these articles in newspapers and think, oh, there's a new drug for rheumatoid arthritis, I'll have a bit of that because it's the latest thing or whatever. And of course, it may not, as you said, be suitable for that individual, where it will be for the next person. And that's why we're so lucky to have such an arsenal, if you like, of medications to choose from, to be able to tailor it to the individual. And there's a bit of discussion going on I'm keeping an eye on the chat in Facebook, and about rheumatoid arthritis as opposed to rheumatoid disease. And this is something we've often debated about. And there's absolutely nothing wrong with you as individuals talking about your rheumatoid disease, but rheumatoid arthritis is the clinical name globally. So I think it would be a very difficult thing to change the name of, and it's more important. I think somebody's made a very good point that I think we've lost Lizzy. Maybe she'll come back in a moment. She did freeze there for a moment. Now people are more understanding of these new terms that probably weren't bandied around in the general public: immunosuppressed, immunocompromised. And if you explain that rheumatoid arthritis is an autoimmune condition, that you're taking immunosuppressant drugs, actually COVID has raised the awareness of these autoimmune conditions quite considerably. So it's not so much about changing the name, but actually changing the public's perception about what this disease is. So as Lizzy was saying earlier, COVID has actually given us some great opportunities to change things and change people's mindsets going forward as well.
Just to let you know, Lizzy is in the middle of a thunderstorm, and the
Oh.
internet has just failed in her house. So
I thought she was looking very stern there for a moment, but she's frozen. So sorry to have, but we're nearly at an end of our session anyway, and I know you have another commitment this evening, Marwan, so we're not going to keep you much longer. I just wanted to say some things that to go back to the BSR's report on workforce. One of the key things that really jumped out at me is the lack of psychological support within rheumatology units, or the lack of access to psychological support. And the next one down from that is about podiatry care. And of course, most people watching this evening, that rheumatoid arthritis really impacts on their feet. And Elsa, I'm looking at you, and I've seen in real life how damaging rheumatoid arthritis can be for feet, and the support that people need to care for their feet. But how can we perhaps engage more with community podiatry if there isn't specialist podiatry for rheumatology support?
There is quite a lot of community podiatry out there. Most of your GP surgeries will either be associated with or linked with podiatry, and people sometimes don't know that you've got within podiatry, you've got specialist podiatrists, you've got people who are orthotists, who can put in, give you insoles, etc., look at the mechanics of your feet. And people very frequently don't realize that you can access that sort of a service, and it is available. And in fact, it's available even on the high street, that you can actually go, and if you're really struggling, finding something that will help, orthotically do your feet is actually available even there. But I'm fairly lucky. My rheumatology department has got a podiatrist. In fact, we've got two, one in Lancaster, one in Barrow. But that's how it sort of like works, in that we've managed to do it very well. But if your rheumatology department doesn't have one, you can actually go to your primary care and actually look for it. Sorry, Elsa.
Yes, Elsa.
I'm just going to say I did a room Zoom recently with Professor Tony Redmond, all about feet, and he's got a kind of campaign going that we're supporting, which is about getting people to ask their team to look at their feet if they've got a foot problem, and not just to think this is just goes with the territory, I've got to put up with this. So from a patient perspective, ask for your feet to be reviewed. And from a team perspective, if you don't have specialty rheumatology, podiatry within your multidisciplinary team, have a team conversation and have a jointly agreed signposting structure in place, so that you can signpost your patients to appropriate local chiropody or podiatry services. And that was the sort of plea that came out of this room Zoom, because 90% of people with RA, if not all the time, but at some point, are going to have foot problems. It's a major issue.
Exactly. And you can still watch back. We have a whole section on our website about looking after your feet, an online tutorial, if you like, in sections about foot health, and you can look back on the session that we had with Professor Anthony Redmond as well. I've realised we've gone over time. Marwan, I really appreciate. I hope poor Lizzie isn't in the dark all night with the thunderstorm. There's been awful rain down here in the south as well today. I thought I needed a boat when I went out rather than a car earlier. But I really appreciate your spending time with us this evening. Just a few things to highlight to our audience, and thank you for sticking with us. There's 80 people watching at the moment, so I really appreciate your time this evening. Few things to remember. 18th of August is our next room Zoom, and our room Zooms, you have to register for those. They will be on the events page later this week, so keep an eye out for that. But the 18th of August, and we've got a lady who will be talking about anxieties about going back into the workplace. going back in public transport now that the restrictions are lifted, and how to handle those anxieties, how to maybe, you know, deal with that, and also about, you know, people can be, for all they mean the right thing, but they're trying, probably will encourage you to do things. Oh, come on to Anti-Flow's 80th birthday. There'll only be 400 people there. It'll be fine. We're all vaccinated. But that doesn't necessarily give you that confidence. And it's really just, how do you handle that bit of peer pressure, perhaps, if you're not comfortable about going out and about yet? And just dealing with all those other anxieties that have come about for all of us, not just the people with RA, having been in lockdown, on dealing with, as Lizzy was saying earlier, juggling work and homeschool and all sorts of things. So that's the 18th of August, our room Zoom. So please do register to come along and join in on that. The hashtag #DoThe20 challenge is now launched. This is our 20th birthday year. It was 20 years ago in October that Elsa, from that, probably that very desk that you're sitting at the moment, that's where NRAS started. You can see it here, folks. That's where it all began. So we're doing a, you know, celebrate our 20th birthday by getting people to do 20 of whatever you like as a challenge. It can be, you know, I'm sure Marwan will be doing, I don't know, 20 mountain climbs or maybe 20 skydives for us anytime soon. But it could be anything. It could be 20 skips, it could be 20 dances, it could be 20 whatever you like. 20 donuts, I think, is something I'm putting my name down to eat. So get involved and share the love, if you like, and help us raise some very much needed funds, because it's been incredibly hard for all charities during this time, because none of these events have been happening. As you know, we don't get any government funding whatsoever, so we really have to raise every single penny to keep doing these sorts of things as well and supplying our services. So hashtag #DoThe20, and you can find out more online at nras.org, #DoThe20. And we have RA Awareness Week coming up. I mentioned earlier, we've got 14 different sessions, all about well-being, exercise, nutrition. Also, they're free. You see, we give these all for free. So please do go on our website, look at events, and you'll see all that's available there for RA Awareness Week coming up in September. And the next Facebook Live will be the 25th of August. Well, we haven't got a topic yet, so keep watching us on Facebook and you'll see that coming up very, very soon. I don't think I've got anything else on my little tick list here. No, I think that's great. It's lovely to hear. We saw the news today that the next chief exec of NHS England is going to be a lady, the first woman to be there. So girl power and all that good stuff. But thank you very much, everybody, for participating this evening. Sorry we couldn't get to all your questions. I think most of you have been answering each other's questions in the chat, but it's been wonderful having you here this evening. And Marwan, thank you so much for giving up of your evening after a very busy, hot clinic. But at least you
problem at all.
For us.
Okay, thank you very much. Thank you
very much. Bye-bye.
Okay, bye-bye.